Okay, so, all right, so I think we'll get started here. So thanks for coming. This is a lecture that I've given different versions of, and it's actually not going to be that long. So lots of time for discussion if you want to. It's just going to be pretty much at a high level, just sort of going in at some of the essential reasons why fMRI isn't more clinical, how it could be clinical, what are the potential clinical applications, and things like that. So to begin with, this was a slide given to me by Scott Hinks, who actually happened to be my co-advisor, co-PhD advisor, but he didn't give it to me a long time ago. He gave it to me a few years ago. He works at GE Medical Systems now, and actually he did back then too. And so they think a lot about, clinical markets and things like that. And so one of his key takeaways here for this slide is basically that MRI is used a lot, and it's used mostly for just routine sort of clinical scans, like identifying tumors or identifying lesions or things like that. And it's that market is pretty much saturated right here. So this is basically a maturity level in terms of how much the market's been saturated with, their ability to do that. But as you can see, I mean, one way, rather than looking at it through purely a fiscal way, just the potential impact that MRI could have on things like depression, Alzheimer's disease, stroke, traumatic brain injury, in terms of functional, is still huge. So this is the size of the circle is basically the size of the population. So that's just sort of like to bring across the point that things like depression and Alzheimer's disease, yes, clinical MRI, I mean, there's certainly research being done on it, but as far as clinical implementation, it's nowhere near has reached its potential. And so there's some interest in sort of pushing this along. So everyone kind of recognizes that there's this huge need for imaging to sort of make more of an impact on either neurologic or psychiatric disorders. So the first part I just want to mention just really quickly is that this is your typical clinical scan. So and basically this is to highlight, this is just basically a T1 scan, a T2 scan to highlight regions where I think one's a diffusion weighted scan, to highlight regions where there's tissue damage due to a stroke. And this is clearly showing tissue alterations with a tumor. And so one thing I want to convey to you here is that this is the reason why MRI is so successful, is that you can just make an image and with almost no processing whatsoever, a clinician can just look at it and say, oh, here's a tumor, here's a tissue damage. And so that's why there's no steps in between, there's no processing, there's no statistics. It's just simply a clinician taking a look at an image that was just reconstructed the moment it was scanned. So that's actually, because of that, I mean, that's sort of a key element to fMRI becoming clinically implemented. So as far as doing fMRI, so what can we actually, and also here's another thing too. I mean, this is one thing that I'll sort of dwell on a little bit more as the talk continues, is that these are single patients. There's no average population that we're trying to infer from or anything like that. It's just one patient, you put them in, and you can identify something immediately. And so the effect size to noise in this is huge. It's probably over 10 to 1 in terms of identifying these lesions and identifying this tissue damage. Whereas in fMRI, it's a little bit different. It's about 1 to 1. So what can we see in an individual with fMRI? Certainly we can see activation. So, this is just, once again, this old movie that I like to show, basically of subject tapping their left fingers, then right fingers, and so on. And you can see that. And so this is one argument that when I first brought this up about almost 8 years ago, in the context of a BSc, I said, one of our goals is to scan individual subjects with fMRI. And one of the BSc members, who was actually quite senior and experienced with fMRI, said, oh, well, you can see individual subjects. You can see when they tap their fingers, you can see the brain light up in the appropriate place. And that is true. You can easily see individual subject activation. But the things that you can't see are, you can't tell whether the subject might be left-handed or right-handed. You can't really, there's secondary comparisons. So you can see activation, but you can't differentiate the subject. So one example is, really clearly is that maybe a psychiatrist can talk to a depressed patient. They make sounds than words, but to be able to differentiate them from being a depressed patient versus non-depressed, there's subtleties in what they're saying that convey that information. Whereas with fMRI, there's a lot of subtleties in activation that convey this clinical difference in activation. So we can't tell much of those subtleties, those secondary effects from the fMRI scans. So, but we can certainly see modulations with activation. Like, if you have a checkerboard different amounts, if you have a task that's increasing difficulty or whatever, you can see differentiation as well. So there's hope. And we can certainly see patterns of correlated activation or activation that are related to behavior, perception, conscious state, all kinds of things. And I'll go into some of those in a second. So, while anatomic MRI has been extremely successful, so why has fMRI made almost no inroads? And like I said, the key issues are there's several processing steps involved. It's a very small effect size to noise ratio. With clinical MRI, when you're looking at a tumor, it's about effect size of 10. With fMRI, when you're looking at even things like biomarkers or trying to look at subtle differences with a patient population, the effect size might be 0.1 as opposed to 10. So it's really hard. It's really small effect size. And so I'll talk a little bit about how to leverage that. And of course, there's many potential artifacts and false positives intrinsic to fMRI that are potentially problematic. So nevertheless, and this is just really quickly, a few examples how MRI and fMRI are exquisitely sensitive to individual traits. So this is a study by Jeff Boyton's group, relatively recent, about maybe a few years ago, basically showing that they can measure by the size of a person's functional visual cortex, they can measure relative visual acuity. So if a person's visual cortex is slightly larger, their vision is slightly more acute. So that's a trend that's easily seen. However, if you look at each subject, there's no way that you can actually predict a subject's acuity individually by fitting this to a curve. You can to some approximation, but it's not above 60% accuracy in that regard. So there's a trend that's reportable, but once again, if you take one subject and try to predict their acuity, it's much, much more difficult. This is some work by Emily Finn that she published recently in 2015, just showing basically with these two networks and the connectivity in these networks during resting state, you have sort of a predictor of about 60% of intelligence. So you can see, once again, there's a clear trend and it's significant. However, if you look at each one of these subjects, it's very difficult, above 60% at least, to predict their intelligence from that. So you can't really make a diagnosis or a statement about that because there's just too much variation around this curve. If all these subjects were very close, then you could make much more progress. Here's an interesting example as well of predicting based on the relative activation when a person plays a video game for the first time. You can predict their later success in the video game. So I won't go into the details of essentially what they found here, but basically there's specific areas that show activation with good learners versus poor learners for video games that are very predictive of whether you learn a video game or not. So this tells us a lot about the brain. It tells us a huge amount. At the same time, though, it's much more difficult to, once again, take a subject and try to predict their scores to any degree of accuracy that is, high enough to be a clinical prediction to use. And then lastly, even in spectroscopy, a relatively noisy technique, people have found that the amount of GABA in this case, a specific part of the brain is specific, but is directly related to their score on sort of an impulsivity score, essentially. So that's also pretty nice. And these points are relatively close to a curve, so this might almost be something that's predictable. Oh, one more thing. Resting state is also very useful as far as that's concerned. Vince Calhoun has been pretty much his group in New Mexico. Now he moved to Atlanta. Has been pioneering pretty much using resting state to make diagnosis about clinical populations. And in this particular case, he actually looks at a resting state connectivity matrix over time and finds that there's about 5 different types of matrices here. And then what he does is something unique, where he determines the dwell time of the matrices, how long the subjects stay in those states, these connectivity matrix states. And he finds that there's differences between those with schizophrenia versus those who do not have schizophrenia, and also the relative fraction of the state time as well. So there's information about subjects that's everywhere, literally. If you just look hard enough, it's all there. The trick is actually being able to leverage that information well enough and with a high enough fidelity such that you could actually make a statement about a new subject coming in. So, and just really quickly, there's even anatomic. So these uses for fMRI or MRI are not really used clinically. However, there's a really nice paper that showed summarized all the morphological sort of differences between normal subjects or maybe subjects based on either their personality. These are actual structures or size of gray matter, thickness of gray matter that was different across all of these either personality types, intelligence. And once again, it's hard to know exactly how statistically significant these data are, but they're enough to show a trend that's in a review article that, reaction time, response conflict, speed accuracy trade-off ability seems to show some correlation to specific structures, and so on. Metacognition, ability to see illusions, and the switching between competing percepts, once again, seems to show some anatomic differences. If you look closely, you can probably find it. So just to take one step backwards here, so fMRI is used clinically. It's used in a very limited way. So back in 2007, everyone was kind of excited that fMRI was finally given what's called a CPT code. It means that it can be used in hospitals and clinicians can bill for it. And so what it could be used for typically has been these 2 things. The first is pre-surgical mapping. So typically you put a subject in a scanner and you find out where their lesion is that you want to take out, then you map out the areas close to that lesion in order to avoid them. However, this is actually still wrought with potential artifacts. I mean, here large vessel effects, while in research they're problematic, here could make the difference between cutting out someone's motor cortex or not. I mean, it really makes a difference. And so it's used in a very limited way, but it's still used. And also the big problem here is not only making statistical maps and actually worrying about false positives or false negatives, but also, in this particular case, registering the maps with the anatomy. We can certainly do that in the context of a T1 scan, but when you actually have a surgeon opening up a brain, you need to have certain other landmarks like vessels and other things like that are registered to the functional imaging. So the processing and the display is much more involved for actually using pre-surgically. And also, of course, when you open up the skull, the brain usually distorts as well. And so that can also be, that's why you need these relative landmarks to mark them. And also fMRI is potentially used as a way for replacing the WADA test. So the WADA test basically involves anesthetizing one side of the brain or the other in the case of either epilepsy surgery or whatever. And it's pretty easy to replace the WADA test because you can actually look at where the language dominance is, which typically correlates with the WADA test results. So you could easily give a language task and just simply count the voxels on one side or the other to determine language dominance, which has been used to replace the WADA test. Okay, I'm not going to talk about all these applications, but I sort of brainstormed for all the potential applications of fMRI. I'm just going to talk about pretty much the top 3, and that's it. But just to give you perspective, certainly we would love fMRI, since we can actually differentiate so many different populations with various aspects of fMRI. We would love to take that one step further and actually make a biomarker that we can then use as a template to compare new subjects and further diagnose them, or at least complement some of the other diagnoses. We can also look at, this is actually surprisingly good application, looking at perfusion deficits by measuring the relative bold latency with resting state fMRI. Neurofeedback has been talked about a lot. There was excuse me, my little bit, I was sneezing a while ago, and so I'm still recovering from that. There was a really nice talk by Mikhail Ramat on neurofeedback. And also, fMRI this might be an emerging technique where you use fMRI to localize specific areas in an individual subject that might be relevant to using then TMS, for instance, to either lesion it or not for therapeutic interventions. Adrian Owen has talked a lot about, and I think I'll talk briefly about this as well, assessment of locked-in patients. So really dramatic results if you have a patient who's unable to communicate, unable to move. They can still activate the brain in unique ways, and so you try to have them do specific tasks that communicate with you via their brain activation. There's a lot of basic neurophysiology that's obtainable with fMRI. And so this is sort of untapped in terms of looking at basic disorders, brain metabolism, neurovascular coupling, and blood oxygenation assessment. Perfusion deficits using ASL. This has actually been around for a while, but because ASL can't quite compete with gadolinium in terms of sensitivity, it still hasn't quite emerged as a leading technique for looking at perfusion. This has been used a lot, potentially, for localizing. So when you have a seizure, if you're lying in the scanner, if you have certain types of epilepsy that causes seizures to occur without motion and enough that they could be going on while you're in the scanner, you can localize the seizure foci more accurately than the EEG, and much more accurately, and be able to operate them. And also, of course, this can't be underemphasized. I mean, it's not just, we're doing basic neuroscience research, and that's clearly where it's been having the biggest impact. But this does translate to clinical practice in one way or the other. So that has to be still an important clinical application of fMRI, is just understanding the brain a little bit better. So starting with biomarkers, the idea is this, and this is just sort of, I think I got this from a paper by Klasino Stefan, who's been thinking about this a lot, more than most people. And the idea is that basically you have to collect a ton of data, a bunch of subjects in the range of thousands, and either use, and I'll go into this, maybe genetics research, but also fMRI research, have all this data, do a massively multivariate analysis of the data. The key trick here is to find the right features to actually pull out. But then if you're only looking at one feature or two features, there might be not enough dimensions to leverage differences in subjects. But if you actually have like a 10-dimensional data space of all really interesting features that are unique, that might be able to be enough to then make a multivariate template to then compare against new subjects coming in, to be able to say with more than 90% accuracy that they have this disease or not. But that's pretty much what it takes. And so the idea is that you have this template, you distribute this all over the country, and then you put a subject in the scanner, you compare them with this template, and then you get your diagnosis. So that's the idea. So here's just I was trying to figure out ways of graphically illustrating this problem. So once again, these are like the plots that I showed in the last several slides about all these trends, where if you have some fMRI measure, it could be either size of activation or magnitude or correlation, and then you have some behavior measure. And you have all these subjects on this curve right here. And you want to differentiate between, maybe this population and this population. So you have two distributions right here, two Gaussians, let's say. And you could actually make, pretty easily, a significant map of difference of activation between these two populations, pretty easily. And this is what most group studies do. But then if you have a new population or a new person coming in, who's somehow their fMRI measures bring you right at the interface of these two, how do you do this? How do you actually put this person in this group versus this? It's almost impossible. So this is what I just mentioned. And not only do you have a hard time putting a new person in, but we don't even know. So here it assumes that you have some sort of gold standard. In this case, is a behavior measure. But if we're even looking at clinical populations, we have the DSM-5, DSM-4 guidebooks, but they're not even. It's not even clear if those guides of mental disorders correlate with anything biologic. It's simply, some would argue that it's a slightly arbitrary delineation that psychiatrists have made to differentiate subjects, whereas it's either more of a continuum or there's no clear biological or functional underpinnings to those. And so one of the whole goals of what's called RDoC at the NIH is to find the biological underpinnings of these psychiatric disorders to sort of further refine the assessments of those, to make it all biology-based as opposed to purely behavioral-based. Yeah?
Hi. Do you think using a dimensional analysis of psychopathology instead of a categorical method will help fMRI correlate better with the results, or do you think it's kind of a moot point whichever way you use it?
It might. It might to the extent that the dimensions in the behavior correlate with some measurable dimensions in fMRI. It might. I don't actually know enough about that, the multidimensional assessment, to know, what sort of behavioral dimensions they're assessing. But clearly, I think that's a better approach than just sort of a categorical sort of thing, because I think the idea of with any of these psychological disorders, they're a spectrum of potentially multiple things. And so if you can actually break it down to some sort of underlying model of what's going on, then that's better, either for both for diagnosis and for just understanding it. So, yeah.
And also, I feel like it's important to note, just with the way you're saying how neurological exams go these days, you're automatically opening yourself up to things like ascertainment bias and just very, and so that itself is an issue currently.
Yeah, no, right. There's all. Right now it's sort of in a state of. Neurology is a little bit further along than psychiatry, but psychiatry still, both of the fields are there's still like an edge between what people know and what they're practicing versus what they don't know, and it's sort of like an art in some way. And so the idea is to really, better understand these underpinnings a little bit more, such that we can actually then make models. So. Okay, so I feel like I'm beating a dead horse here, but still, so group differences, we can definitely see a lot of different things. Individual classification at a rate of better than 90%, we might be able to do for language dominance, but for all these other areas, everything from gender, sensory motor, personality, psychology, and so on, to create these biomarkers, we have a lot of studies that actually show with limited populations some measure of success. But as other people could argue much better than me right now, is that there's a clear underpoweredness to a lot of these studies that while you might get a positive result, and let's say differentiating those with Alzheimer's or not, there's a good argument that unless you have maybe on the order of 500 subjects or 1,000 subjects, you can't really use that to then onto a new population or a new individual, even though you get some sort of trend. So they're all trends, they're all suggestions. So this was a nice paper that sort of summarized the issue of making biomarkers. And so I'm not going to go over this again. I kind of talked about it already. Just to emphasize a few things. One is feature extraction. So you might have functional and anatomic lots of data, but it's not just to sort of take all the data. You have to figure out how to, and this is a big part in this machine learning. You have to figure out how to compress the data, how to reduce it to something that varies with each population or with each subject that's measurable. So that there's a lot of dimensionality reduction of the data that first has to occur. And that's kind of an art in itself. Then the feature extraction goes with that. And then you create a model. And it's important to note here that there's several efforts at making different types of models. One, as Classino Stefan, he's at Zurich right now. He's basically trying to create these, in a sense, generative models that the idea there is that if you have the model fit the data well enough, then there might be latent variables within the model that are really the variables of interest that you can assess. Other types of approaches are just brute force machine learning approaches that just take this data and just try to figure out how to organize the data such that you can optimally draw, and this happens to be just 2 dimensions. So the idea here is that you have these 2 populations that certainly overlap in 1 dimension. So let's say you just took maybe, and this, don't worry about these axes. Let's say fMRI magnitude here and maybe fMRI correlation here. So they overlap too much in any 1 dimension, but with 2 dimensions, you can draw what's called a hyperplane between these distributions in 2 dimensions. This is very optimistic, obviously. So the idea typically with fMRI is that you have more than 2 dimensions. You have maybe 5 dimensions of how to collapse the data. And then in this 5-dimensional space, you'll have an algorithm that searches for a hyperplane that maximally differentiates this population from the other. The worry in doing that is that you're overfitting. So you might be able to draw something that has idiosyncratic features of just that population, which might give you a good result, but it's not correct. And so it will quickly show up if you apply it to a different population. So you have to worry about, when you're trying to draw these hyperplanes, you have to worry about overfitting to do that. All right. And of course, then you have to test it, and then you have to do clinical trials on it. And to even complicate or help matters more, this is what I just showed was this neuroimaging phenotype right here. But you can complement all this and maybe constrain it further by looking specifically at the environmental background of the subjects or the biological pathways of specific genes. If they have a specific genotype, that might constrain how you organize the subjects, and it might make the fMRI maps even more informative. So people are working on, using everything from genes to imaging as data, as dimensions to look for further classifying subjects. Okay, that's just that again. All right, so once again, elements of a classification pipeline. You have the training, you have the data set, feature extraction, model training and optimization, or model creating and training and optimization, then finally application of test data. All right, so that's the biomarker part. I'm not going to go into too much more depth there, just because of the fact that it gets pretty involved pretty quickly. But just to give you a perspective, this is a major area where many groups are working on. So it's something to be aware of. All right, so back to potential clinical applications. Let's look quickly at this really unique paper that was brought to my attention about a year ago when I was writing a blog on clinical applications. It's called Using Bold Fluctuations During Rest to Extract Perfusion Deficits. So all they do, it's very simple. They just look at resting state, they average the global signal, and use that as a latency reference. And then basically they compare the latency of the overall signal in each voxel with that global signal as they shift the time. And so whatever correlates best with what time gives you an indicator of what the latency is. So in most subjects, these maps should look more uniform. But this is actually a subject that had a stroke. And you can see that if you just measure CBV, it doesn't really show up. If you measure the gadolinium delay, which is a very sensitive measure, it involves injecting gadolinium, the stroke clearly shows up because there's a delay in delivery of blood there. Pure resting state fMRI, where you don't look at latencies, it doesn't really show up that well. However, if you look at the resting state fMRI where you're using the global signal as a reference and you're shifting that and finding out when the voxels maximally correlate, then the perfusion deficit shows up really nicely as well. So this might be a way of replacing gadolinium injection. And it's interesting because, there's no biomarker here, there's nothing. This is a pretty large effect size to noise, and it's potentially immediately useful in subjects. Certain amount of processing here, but it can be automated. All right, neurofeedback. I was actually kind of surprised. I saw this review. It's sort of an article online, and I was actually kind of shocked to see that even in the past few years, none of these papers are that old. From 2000, oldest is around 2012. That neurofeedback has actually been tested and used for a variety of disorders. So that's just an example of how many papers have been published related to trying to implement neurofeedback clinically. Here's an actual example, and this is sort of illustrates as Mikhail Ramat said in her talk, that some of the problems with doing real time. And that is, so basically this was a task where subjects had to either further activate their emotional network that was indicated by either the insula and some subcortical areas right here, or activate as a control their visual network, which is just, faces and places and visual cortex and some other, and mostly in the visual cortex here. So they were told either selectively to activate the emotion network, which theoretically that's what helps alleviate depression, or activate their visual cortex, which is a control. And what they found is that this was a score that is the relative depression score. And they found that regardless of what they did, their depression went down substantially within the first 12 weeks. And only in the last few weeks of treatment was there a differentiation between this placebo effect and enhancing emotional networks versus enhancing visual as a control. So there's this small difference right here that's some additional effect. And also in terms of how quickly they, or whether they had remission or not, how quickly they became depressed again later. It turns out that this lasted, that there was a less of a remission rate when activating the emotional networks versus not. So versus trying to activate the visual cortex. And so the technique works, but it's only a little bit more than a placebo. And that's pretty much the case for a lot of other studies that have been seen. Okay. Here's an example of epilepsy localization. So this is one, just basically a global activation map using the epilepsy signal as a regressor. The other one is doing a certain amount of independent component analysis to actually identify areas specifically that seem to overlap with where, in this case, there were electrodes that were implanted looking at the epilepsy seizure. But clearly it actually shows up. There's a lot of other areas that might be secondarily activated, so it's not a perfect technique. Nevertheless, with certain types of epileptic patients, it might be really useful for localizing the sources. So it's a nice paper right there. And as I was referring to before, there's also ways of communicating with locked-in patients. So this is some work by Adrian Owen some years ago in Science. Essentially, you can see that this is the locked-in patient. You can see looks like they have some sort of large lesion on their head from an accident or something. And the idea is to either picture yourself playing tennis or spatially navigate. And then when they asked the subjects or the controls obviously could do that. They get this sort of pattern of activation. In this case, the subject was completely unresponsive. They just wanted to know if they were conscious or not at all. There was no way of knowing. So when they asked them to do these sort of things, they were able to activate these specific networks. And you can imagine then further communicating based on your activity in your network. So this is potentially a useful technique for assessing level of consciousness of locked-in patients. So, all right, so finally, and I believe this is my last slide. This is more of a discussion than anything. So what's needed for clinical implementation? So as I mentioned, we really need, in order to jumpstart even fMRI being used more in the first place, I think we need a really nice pipeline for acquisition to all the analysis steps for display, so radiologists can actually look at a display that's meaningful almost immediately. That doesn't exist right now. So there's nothing like it that exists. Maybe the closest thing right now is, like having AFNI, which is good, but it's nowhere near kind of what's needed. Although the problem is that typically with research, you want to balance out flexibility with something that just works. It turns out that with AFNI, there might be a certain amount of flexibility programmed in that the clinician wouldn't need, and so you have to, obviously, when you're coming up with a product, you have to narrow it on that. You need more attention by vendors in the first place. So typically, the entire field of fMRI is lucky, as I've mentioned before, simply because we can do fMRI on the scanners. But the vendors, since the clinical market for fMRI is so small, and the research market is even smaller, they don't really care about developing scanners for fMRI. And if we could actually get, and this is the next part, just one major clinical application of fMRI, one killer application of fMRI, that would draw the attention of the vendors, and it would jumpstart the advancement of fMRI to more clinical implementation, since then it will be within their interest to develop these platforms so that methods can be tested more in the clinical realm. Right now, that doesn't exist because we haven't quite got our foot in the door enough to actually use fMRI clinically. So, and of course, I mentioned sort of roughly what a biomarker is, and sort of finding, many studies actually trying to pull out individual differences. Right now, the field is kind of all over the place. There's some debate as to how many subjects you need and how to verify that your biomarker is actually correct. And so this will evolve pretty rapidly as we have more shared databases and things like that. But right now, we don't have any biomarker standards right now. We just have, papers that claim 90% accuracy that are later disproven and things like that. So that's where the field is right now. There's some amount of turbulence in terms of assessing individual subjects and what does it mean statistically to be able to say something about an individual subject. So that's where we are right now. I think things will continue to progress, but it's not clear exactly how fast. I think that they'll really accelerate once we do get one really clinical, sort of unique clinical application that other techniques can't do. And it is actually cheaper and easier. So, all right. Okay, with that, I'd just like to thank you. Thanks. All right, any questions? Anything? Yeah, back in.
Thanks for your talk. Just going back to the discussion you had on the biomarkers. So I'm just curious as to how you would justify the cost. So clearly, insurance companies charge like thousands of dollars for MRI scans, and then layering on top of that, genome sequencing and other labs. It is a huge cost, and especially when you're deriving your classifiers from a DSM, right? It becomes very circular. So, how would you move forward from that in the sense that these classifiers are built on the same categories that you're kind of criticizing?
Right. So that's the hope then. Yeah, so that's one of the hopes of RDoC is that that somehow in looking at the data itself, that these categories will organize themselves or cluster on their own. And then these clusters will either line up or not with the DSM categorizations. So that's the hope. You know, there's no obvious indication that that's really working that way yet. There's not enough subjects. And I agree. I mean, all this research is expensive. And if it just gives you a really expensive way of being able to just substitute for psychiatrists, a good psychiatrist is looking at a subject and saying, oh, well, you're this, then it's not worth it. Then it's definitely not worth it. If it can not only help diagnose, but sort of maybe through the imaging point to areas that if they're stimulated or not, or whatever, that might be added information that could be useful if it's effective for treatment, a little bit more effective for treatment. But yeah, no, I agree. It's circular to try to use the categories to drive the analysis. So the hope then is to have the analysis sort of self-organize. Yeah. Yeah.
Thank you, appreciate it. Okay, so one of the things that's always concerned me in this field is it seems to me that there are many silos with respect to brain data being acquired in independent modalities, and there's not a lot of work that I see in fusing the modalities. So do you think we could make progress in the clinical area if we concentrated more on fusing modalities such as fMRI and along with like MRS, where we could get information about metabolite concentrations, or with PET, or other, possibly felicitous combinations of these?
Yeah, no, definitely. I think that especially gives you unique dimensions to triangulate a disorder from. So I completely agree. I think that until we are shown otherwise, that there's too much overlap or just one modality is completely noisy or something, it's always worth trying to integrate the modalities. And I also agree that that's something that's only a few labs can actually do well. And it takes a lot of resources to be good in multiple modalities and good enough such that you can actually bring them together. So, yeah. Hopefully that will somehow change as people become more convinced to do that. Well, here at the NIH, we have at least, our Center for Multimodal Neuroimaging, which that's kind of the goal, to be able to be the glue that sort of ties in different core facility modalities together so that researchers can use all those better. So, okay. All right, well, thanks. I think next Thursday, this coming Thursday, will be Eric Wasserman talking about whether neuromodulation is useful or not, I guess. So, all right, thanks.